Okay, so my special topics is about grief experiences related to ALS. This project, or the way I've designed the presentation is beginning with an introduction to ALS, followed by the scope of the disease, and then the known interventions and support measures. So the introduction to ALS, amyotrophic lateral sclerosis is the official name. It is also known as Lou Gehrig's disease. He was known as, or he was a New York Yankees baseball player who was diagnosed at age 37 and lived 2 years after his diagnosis with ALS. Also, Stephen Hawking, who is a physicist, was fairly well known as an ALS patient, a patient with ALS who was diagnosed at age 21 and lived 55 years, which was quite remarkable and is the exception in the case of ALS. Most patients do not live that long. Currently, 30,000 Americans live with ALS. 15 people are diagnosed today. It is a fatal disease affecting an individual's motor neurons. They slowly degenerate, causing the muscle to weaken and atrophy throughout the whole body. It usually starts on one side of the body, and eventually the person will lose all voluntary muscle movement. Their foot might begin to drop or drag. They might lose their hand grip. Frequent falls and trips, very common. In the final stages, they'll even lose their involuntary muscle movement, and they might have difficulty breathing and speaking and swallowing. Usually, cognition is not affected in ALS, but that is not always the case. Progression is not the same for everyone. It is unpredictable, which leads to substantial different types of grief. As we'll see later, average life expectancy is 2 to 5 years after the diagnosis, and the diagnosis can take up to 1 year. The average age of diagnosis is 55. The scope of the disease. The way that ALS impacts people's lives is significant. It is multidimensional and affects many different levels of not only the person with the disease, but the family members and those around them, the caregivers and loved ones. So there is no cure for this disease. The family of the loved one will witness their deterioration slowly over time. It is extremely painful. It does impact Erickson's stages of development, so especially the last 2 stages, which can cause some stuckness in either of these stages. Generativity versus stagnation, where this is the phase where a person is productively working to make their mark in the world, and this can be impacted by ALS where they're no longer able to work. And then what is their mark that they're leaving in the world? Integrity versus despair is another stage where it reflects on life as either fulfilling or regretful, and this is a time where you might be dealing with that at an earlier age than you would normally expect to. Anticipatory grief is experiencing a grief before the loss. It is mourning a future loss over which we have no control. It is a very complicated type of grief that upends the order of one's life. With ALS, there are significant changing of roles when a parent or a spouse needs full-time care that previously was living completely independently, and also loss of employment significantly impacts a person's life, especially if they had a career that they loved, if maybe they were identified with their career or their job, but also there is significant financial strain. There are substantial costs with this disease. A downward spiral effect happens with ALS. First, when you get diagnosed, a person might have denial and shock and ambiguity, not even really knowing how to feel. There are minimal symptoms at this stage, but they are beginning to lose a sense of who they are, who they thought they were, and they might bring a negative or a fearful outlook for their future. Then secondarily, as the symptoms progress, reality starts to set in, and they start to have visual evidence of the losses that they were fearing, like their home needs adaptations like wider doorways or raised toilet seats or raised counters or wheelchair entrances in and out of the home. They need a special car for transporting wheelchairs. Their utensils need adapting. Suddenly they need the help of a caregiver when they didn't need that before. They need to financially plan for equipment, technology, a minimum of 1 to 2 wheelchairs as the disease progresses. Not all family members are ready to make these changes that are needed. And then it also requires prepping for losses early. So they will need to record their voice technology, for example, before their voice goes, so that they have their actual voice when they need to use technology to speak. Ordering wheelchairs can be something they never expected to do. They might have thought they might be ordering a car or some other special type of thing they were anticipating and excited about buying for in their life, and that is now going towards a wheelchair. It can be extremely disenfranchising. They need to now find a handicap mode of transportation. They might even have to have surgery to place a feeding tube before the respiratory system becomes too compromised to have surgery. The cycle of burden is another scope of this disease. It is the pattern of the increased burden on the caregiver combined with the feelings of guilt and shame and dependency that the patient has needing the care. This can often lead to both of them withdrawing from each other. This can lead to social isolation, loss of connection, and it can risk prolonged grief setting in. It can feel like a constant state of loss, like thinking thoughts through prevalently, like I'll never be able to hug my kids, or I'll never be able to wash my hair, or I won't even be able to use my own voice. It is, as you can see, a deep, unrelenting sadness where grief is always present, sort of a slow death. So known interventions and support measures. In general, family support is essential. This, especially with this disorder, because there is so much dependence that the patient is going to need for care. And the responses from family members can vary from open and engaged to closed off and isolated. Open engaged is optimal, where family vacations are planned around the patient as the focus. This is an example of an open and engaged family response. Externalizing the disease and not identifying with it, recognizing that the individual is more than the disorder, and addressing conflicting thoughts. For example, the family not wanting their loved one to die, but also feeling exhausted, and also a patient being resentful, but also wanting to live. Finding meaning. This is something we talk about in many of our stages of grief. In meaning making with ALS, we want to focus on how they can live the rest of their lives. Recognizing that the patient is more than the disease. The disease has taken a lot from them, but what can they do with the time they have left? Recognizing that letting go does not mean to stop living, but to find a way to hold on to memories and also to be present. That is so often the case, but especially in ALS, when that's really the power that you have is what you can accept and handle in this moment. It is giving them the autonomy to experience living with ALS in their own way, and having a witness to observe and validate the patient's suffering and existence, family members, friends, community, that validate and make that patient or a person be seen. Teaching emotional expression skills. These are ways that a person can find meaning living with ALS. Resilience depends on virtues, coping skills, mental health of the patient and the caregiver. Elements of resilience with ALS include problem solving. So many problems come up with this disease. Social support is so necessary. Hope is really, really important and difficult to find in the face of this disease. Optimism as well, and spirituality. giving bigger, broader meaning and context to what a person's undergoing who has this disorder. Building resilience gives the space for improved coping skills, which can prevent chronic emotional distress and improve the quality of life for both the patient and the caregiver. There is a program called Resilient Together that is ALS specified. That's an early intervention program. It sets realistic goals to focus on the patient and not on the long-term negative thinking. And the goal with this program is to simply be, which will reduce the stress and minimize worry. Also, mindfulness is very important. This is based in existential theory and the life-death cycle, emphasizing that life includes suffering and being able to accept that and the limitations imposed by this disease. And in doing that, one is encouraged to observe their thoughts and feelings and not identify with them. Sort of this idea of riding the wave, but not getting caught in the wave when life gives you waves, which will be the case with ALS. And then also just having compassion towards themselves the same way that they might have for a friend. Positive thinking practices, not just saying to be positive, but actually actively doing it, noticing positive things throughout their day, and be aware of their experiences, through their senses in the practice of grounding. Coping strategies, dyadic coping. Each person's coping style interacts with and affects the others. So this kind of two-part component of ALS is really unique to this disease. It is as impactful for the caregiver as it is, or caregivers, usually it takes a team, as it is for the patient. These are important because the patient's level of dependence on the caregiver is high and the demands on the caregiver are also high. So this can be most optimally if they are supportive of each other, but in the case that a hierarchy happens, there can be isolation, hostility, negativity when that gets out of balance. Some specific techniques for coping is to use humor. Always a good strategy. Seek knowledge, embrace spirituality, learn problem-solving skills, and positively evaluate daily events as much as possible. Coping is the strongest indicator for quality of life for patient and caregiver, research has shown. Supportive communication of the diagnosis is really important. When that diagnosis time actually happens, it's best to deliver it with a psychological support team that can provide resources and draw attention to coping and resiliency factors. And then there's also dignity therapy. The patient is the driver of these therapy sessions where issues discussed are where the patient considers most important. Focusing on what they can do and creating a legacy document might be an example of that. Something that they can do and helping to ensure that they can carry that out. Allowing the patient to decide how they want to be remembered is another one of these techniques in the dignity therapy. And then also I need to touch on the dual process model like we've talked about. This evaluates current problems, but does so in the context of one's own life. There are so many problems with ALS. It considers the short and long-term goals and problems, and it processes emotional reactions to both the immediate response to the diagnosis as well as living the greater, broader picture of living with ALS and the feelings associated with that. And it focuses on, again, problem-solving skills while also looking for ways to make meaning and strengthen resilience. And a final note, the ultimate challenge embedded in the grief experience of those affected by ALS is living a significantly compromised life and how to do that in the present moment while preparing for future loss and striving to maintain hope amidst a near constant state of loss. It's a really monumental challenge. And I wanted to just close with a quote that I had from a friend of mine who lost her husband to ALS and gave me some really good perspective on not just dying, but specifically dying in this particular way. And what she said was, ALS allowed us all to say goodbye in as many ways as we could think of. It gave us so many rich experiences, even in the deepest sadness and pain. Tom taught us all how to live and how to die. Thank you very much.